Our third speaker is Peter Washer. He is a professor of, he has a PhD in medical ethics and law and education, and he obtained it from UCL. He is a member of the Clinical Communication Skills Unit. He has taught clinical communication at Imperial College in London. He also taught courses in medical ethics, communication skills, education in several leading universities in UK. He has a wide experience of teaching both undergraduate and postgraduate trainees. His book, Clinical Communication Skills, has been published by Oxford University Press some years back. Now he currently works for the King's Health Partner, King's College in London. Please, Dr. Peter Washer.
Thank you very much for that introduction. Can I just check that you are hearing me okay? Is everything okay? Yeah?
Yeah,
I'm assuming so. Yes, I'm really honoured and delighted to be invited to this conference. My only disappointment is that I'm not actually there in ABHA. I have actually worked in the Kingdom a very long time ago, in about 1990, and I have visited ABHA, and I was really looking forward to coming back. But then the pandemic happened, so here we are. My original title was more focused on faculty development for assessing clinical communication. But with your permission, I have broadened that a bit because I wanted to talk more generally about, I think teaching and assessing clinical communication is actually two sides of the same coin, and I want to talk about that. About me. Okay, as per the introduction, my academic background is in philosophy and medical ethics and law. I've worked in university since 1997. Before that, I worked in a charity working with people with HIV-related dementia, and that was quite intense, and I burnt out and ended up moving into academia. I've done faculty development roles across universities and worked in pretty much all of the medical schools in London. More recently, I've been an educational advisor to the Royal College of Radiologists in London, where I wrote the first teaching qualification specifically for radiologists and oncologists. So I just wanted to say, if there are any oncologists or radiologists with an interest in doing a master's in education specific to them, please do go and have a look at the University of Dundee's website. There's an online course there that you might be interested in. And I actually resigned my job at King's College London before Christmas. I've recently done an MBA, and I'm now working as a freelance educational consultant, doing management consultancy for healthcare organisations and running faculty development courses on teaching and assessing clinical communication. I've just done one of those in Poland. My research interests, as my career is also not a very straight line. My research interests are also in public understanding of science. And my PhD and postdoc work was looking at how people made sense of emerging infectious diseases such as SARS. So you can imagine that my citations over the past couple of years have gone like that, which is great. But that's not what I'm going to talk about today. I'm going to talk about my work in clinical communication skills. And as I say, around about 2003, I got my first lecturing post teaching clinical communication at University College London. And I inherited a curriculum at that point that was largely about medical history taking. And I thought was actually quite satisfactory. So say, for example, the point in the curriculum where the students came to taking a sexual history, there was a kind of checklist of all the information that they needed to gather in a sexual history. And then, the assessment really was whether they reached the right diagnosis from the scenario. And when I saw this session first, I was just thinking, is that it? Is there nothing, where's all the other stuff? Because, medical students are generally young, junior doctors are young, and you've got patients that are frequently much older, looking at this medical student or young doctor thinking, oh my word, this person is young enough to be my granddaughter or my grandson. And similarly, the medical student is looking at the patient thinking, I can't possibly ask all these questions, it's too embarrassing. This woman is old enough to be my grandmother. And none of that was acknowledged in the teaching or the assessment. And I just thought it just seemed such an enormous gap. And similarly, the issues about dealing with cultural diversity, about dealing with disability, about talking about complaints and all these kind of really complex issues were really just kind of boiled down to this medical history taking. And anyway, I felt it was really unsatisfactory. And over the years, over a few years, I did a lot of curriculum development work around those issues, which became the book, Clinical Communication Skills, and published by Oxford University Press. And the picture on the right is me looking very pleased with myself because it won an award at the British Medical Association for the best book in its category that year. This is the area of work I want to talk about today, and my learning outcomes for this talk. We've already had Prof. Sherwood this morning talking about changes to the doctor-patient relationship. I want to add my penny's worth to that. And then in the middle part of my talk, I want to talk about the benefits of clear, effective, and we might say patient-centered communication. I've got some 5 benefits I want to talk about. And then the meat of my presentation is about what was the original title, which was really thinking about, and how do we put that into practice? How do we train up the faculty to improve the clinical communication teaching and assessment that hopefully moves away from this kind of model that is just the medical history and moves towards more patient-centeredness, one that is both more satisfactory for the patient and for the doctor and medical student. So my first point then, what are the changes to the doctor-patient relationship? Well, as we have already heard, I mean, the obvious one is the access to medical information. I mean, if you go back a generation, I'm not that old, but when I was young, we had a Reader's Digest medical, dictionary or encyclopedia in the corner somewhere. I had an auntie who was a nurse, but other than that, I mean, nobody had any access to medical information other than the doctor. The doctor was the sole, or the healthcare professional at least, was the sole gateway to any kind of medical information. And now, patients will obviously, Google their symptoms, Google their diagnosis, Google their treatment, Google their doctors even. Will frequently come in now, and even very old patients will have, younger children and grandchildren who will be doing the Googling for them. And they'll come to the consultation with, printouts of all this information that they've found. And that really alters the dynamic of the consultation. And that's a good thing. Informed, knowledgeable patients is a positive thing. But obviously, as we have seen with the pandemic, a lot of the information out there is just wrong, and patients do not have the research skills to filter and to know where the correct information is a lot of the time. A lot of it can be very dangerous. So there's a different kind of consultation to be had, which is about saying, okay, a good doctor will say, look, it's great that you found this information. Let me just talk you through why you've correctly identified all the potential treatments that you could have. The reason why I haven't suggested these ones are because of the side effects, and I haven't suggested this one because of the cost, or whatever. But it's a different type of discussion. The second point I would say is about less deference to medical authority. I think there's less deference to all types of authority. If you think of, in more traditional societies where we had sources of authority, it would have been, religion, the police, the press, government. I mean, all of those sources of authority are being questioned, for better or worse. And that, again, feeds into this different kind of dynamic between doctors and patients. A third change in contemporary doctor-patient relationships is just really the complexity of what's available to do now. Again, if you go back a couple of generations, if you had, I don't know, cancer of the cervix, the options were really limited. Whereas now there's an enormous range of potential things that can be done for everything. And then that changes the complexity that has to be explained. And, it becomes a much more difficult thing for a patient to think, okay, well, how does this align with my priorities and preferences, this greater life expectancy versus this quality of life, all that kind of stuff. The fourth point is that there are more complaints and litigations. I mean, in some countries more than others, but I think everywhere, a part of this whole different relationship is people are more likely to complain if they feel that they have been hard done by. And the fifth point is what we might call the increasing medicalization of lifestyle. So things that are not really medical conditions, such as aging and obesity and childbirth, become part of, under the scope of medical, the gaze, as you might say. And in response to that, there's a resistance to that medicalization. So we might say the voluntary euthanasia, natural childbirth, LGBT, disability movements, all in their way are trying to demedicalize death, birth, sexuality, disability, and arguing against it being considered as something that the medical has an answer to, and rather as something that is part of the rich variety of the human existence. So, given that things are changing, I wanted to look at some of the research that I used in my book about clear, effective clinical communication. And I've come up with 5 different areas. The first is, with effective clinical communication, you are more likely to get the diagnosis right. Now, put it bluntly, the 3 points, the 3 ways to get a diagnosis. One is the history, one is any tests you can do, and the third is examining the patient. And the medical history always was and still is the most likely one to get the right one. So this is a really old study from the 70s. It was a study of UK medical outpatients appointments, and found that so what they did was they asked the doctors for a diagnosis based on the patient referral letter. Then after they'd taken the history, after they'd examined the patient, and then they checked that diagnosis with the confirmed diagnosis 2 months later. And they found that in 66 out of 80 patients, the doctors found the correct diagnosis on the basis of the history alone. And then Peterson, this is a Canadian study, a generation later, repeated the study and pretty much found the same results. But beyond that, beyond getting the right diagnosis, there's also about scratching the surface and getting to what the patient really is there for. I put real in inverted commas here. And so the ROAD study is a US study of GP visits. And they recorded doctors' consultations with the patients in a general practice setting. And what they found was that, on average, after only 12 seconds of the patients opening their mouths and started speaking, the doctors had interrupted and redirected them. And as a result, they weren't, the patients, what the patients had come there with were being really redirected and hurried along into something that more the doctor fitted the doctor's early ideas of what was going on. The Bell study is a Californian study, and a much bigger one. 909 patients that they looked, and they found that 11% of patients had an unmet expectation, leading to repeated visits. And I know when I give this kind of talk to doctors, quite often they say, well, we haven't got time. But a lot of these studies will say, the patient-centered consultation takes about a minute longer, but it saves in time because the patients don't come back. And yeah, I mean, interestingly, the Bell study also found not only were the patients dissatisfied with them, but the doctors were as well. When they also surveyed the doctors and found that the visits that the patients found to be satisfactory were also least satisfactory for the doctor's perspective as well. And similarly, this is a UK study of GP patients. Very few of them felt able to address all their concerns, again, leading to unwanted and unused prescriptions and repeat visits and so on. Now, the third benefit of effective communication is actually from the doctor's perspective. Now, we know as a professional group that doctors have very high levels of stress and burnout, mental health problems, alcoholism, etc., etc. And so this one study of 27% of hospital consultants felt that they had evidence of mental health problems, and those were more likely to say that they had had insufficient training in communication skills, and they felt that it affected their patient care in the sense that they were quite robotic and feeling and remote from patients. And the Bailey study is an American Society of Clinical Oncology one, very interesting one, which looked at doctors' poor communication skills and thought that, so those doctors who felt that they were less able to talk about death and dying tended to continue to prescribe chemotherapy in the terminal phase of illness, which is, you know, a really interesting and kind of upsetting from the doctor's perspective, let alone the patient's finding. So the benefits, number 4, reduce complaints and litigation. I mean, Charles Vincent at Imperial College did loads of work on safety and risk and litigation. And in this particular study that I've quoted here, he looked at, he interviewed 227 patients who had actually taken litigation against doctors. And what he found was that it wasn't just the original injury. I mean, they wanted it not to happen again, and they wanted to, but actually what was more important to them was having a full explanation of what had happened, and really that the offence had been really, you know, expanded by the insensitive way that the incident had been handled by the doctors, which is actually less about, you know, clinical malpractice and more about the communication skills. And this Ambadi study is absolutely fascinating. They interviewed surgeons talking with their patients, and they just used 10-second clips of the recordings. They played them to psychiatric nurses who were coding against criteria of whether the surgeons were warm or dominant and so on, or patient-centeredness in short. And they found that those patients who were more dominant and showed less concern, they cross-checked that against, they cross-tabbed it against the surgeon's history of complaints and litigation. They found that those that were more dominant and less warm were more likely to have had malpractice claims against them. And again, this is completely separate to their competence as surgeons. So really very interesting stuff. And my final one about the benefits of communication is that patients really love it. I mean, I say this to students, no patient ever said that doctor, their knowledge of anatomy was amazing, you know, their examination skills were fantastic, because they don't understand that stuff. And they expect you to know that, you know, they expect doctors to be experts, rightly. But that interface between the doctor's expertise and the patient's experience is the clinical communication. So a couple of studies here. One showed the strongest predictor of a resolution of headaches. This is a big, I think, Canadian study from the 80s. So they went back to 1 year after first complaint of headaches, and they found that the strongest predictor of the resolution or reduction in headaches was that the patients felt that they'd been able to discuss their problems fully with a doctor at the outset. And this Mumford study is a review, but there are plenty of studies that, I mean, for example, there are studies that split groups into pre-surgical patients into controlled groups and enhanced communication groups, might say. And so one group gets the regular communication that the pre-surgical patients would get. One has more input in terms of doctors or nurses explaining the pain and what they can expect and so on. And then afterwards, when they look at the prescription charts, they find actually that the patients in the enhanced group use less analgesia. So there's really, really interesting studies out there. Now, the eagle-eyed amongst you will be thinking, but those studies are really, really old. And when I was preparing this presentation, obviously my first thing was to update them. And I thought, actually, I'm not going to update them because the point I'm trying to make here is this is a really established body of knowledge that is growing all the time. I'm very keen for people to be scholarly and to engage with the research and read it and do their own research. So when I wrote the book, I also produced this web page associated with it, which is still there. That's the web address. And if you're interested in reading any of the references, on the third bullet point on that list, there's a link to all of the references to the paper. So if you can click straight through, if your organization subscribes to the journal, you can click straight through. But more interestingly, there's also the PubMed link, so you can click on the PubMed links and you can find who's been citing that paper. So if you're interested in communication and compliance, adherence, patient adherence or something, you can go and find what more recent evidence of what people are researching at the moment. I would strongly encourage people to do that. And my point is that there is an evidence base. It has been there for a long time. It really is very established. And I would encourage people to engage with that. So I come to the last point of my presentation, which is about how do we put this into practice? How do we move away from a curriculum that is perhaps too focused on the medical history, and the medical history is still there, the diagnosis is still there. Obviously, it doesn't need to be, it's not supplanted by anything else, but within that, it sits within a discussion with the patient, a negotiation of people. How do we move towards that? Now, I've been talking for a good 25 minutes, and I just want to pause for a moment and get you to think. Now, I want you to think of something that you know you can do really well. It might be something professionally, it might be reading MRI scans, or it might be something out of work. You might play a musical instrument or play sport or anything, shopping. It doesn't really matter what it is, but just something that you know that you are really good at. And I want you to think about how you became good at it. So if you can just hold that thought for a minute. So you've got this thing that you were really good at it. How did you know you became good at it? You might want to write that down. And now I want you to think about this thing, and I want you to think about how you know you are good at it. Yeah, so you've got something in your mind that's something you think, I know I'm good at that. How did I become good at it? Okay. And how do I know, what made that thing pop into my mind in the first place? Have you got it, hopefully? Now, obviously, if I were in a room with you, I would get you to write this on a piece of paper. But from doing this exercise with groups of doctors over the years, I think 90% of them will say, whatever it is, you become good at something by practicing it. And if you ask them how they know they're good at it, it's because people gave them feedback and told them when they were becoming good at it and how to become good at it. So you see where I'm going with this. The practice and feedback are absolutely, at the heart of this. I think they're at the heart of all learning, to be frank, but particularly in this case. This is not something that you can write essays to show that you're an effective clinical communicator. You really need to students need to practice it, and they need to, the way that you assess it is that you watch them doing it, either in real situations or in simulations. The other thing is that it is a really, really difficult thing to do, and it comes more naturally to some people. I think thousands and thousands of medical students I've seen doing simulations, working with real patients. Some of them clearly are more empathic, they're more expressive, they're just more natural than others. But it is something that anyone can learn. I'm really convinced of that. But they need a safe place to learn it because it is really hard, particularly to do simulations in front of their peers and so on. So I think the tone of the feedback, particularly the formative feedback, should always be to hold their hands and walk with them and to build their confidence and nurture their professionalism while they develop their own professional voice, which will be authentic to them. Now, in turn, I think the faculty delivering that training similarly needs to be supported and really have kind of specialist help and support, particularly if they haven't been taught this way themselves. It's just too much to ask people to say, run a simulation if you've not been trained that way yourself, and if you've never done it before. You need some real hand-holding for the faculty as well. And I would say any faculty doing this kind of training for the first time is going to have concerns. I mean, I take my own journey with this subject. I started teaching groups of medical students around 2001, and then, as I said, got my first substantive teaching post just doing teaching clinical communication at UCL in 2003. And in those early days, I was very, very uncertain of it. I didn't like role-playing myself. And I think the thing about students is they really pick up on the mood in a classroom. And if they feel any hesitation, that you will transmit that. So they really need to be, they really need to have a teacher that's really, really enthusiastic about it. An enthusiast, a champion. And so what I would suggest is to identify a group of faculty that are really, really enthusiastic about experiential learning, and get them together. And really, those people that are really reluctant about it, don't think it's all that, or people will quite often say to me, well, no patient ever died from a doctor being rude to them. But the other things are much more important, the anatomy and the pharmacology and all the other things that they have to learn. And I don't actually agree with that, even on its own terms. I can imagine, I can tell you stories of loads of patients who went to a doctor who was rude to them, and they didn't go back when they should have gone back, and soon enough they're overtaken by events. So I think go with the enthusiasts, the people who really are keen to do things differently. And take them out of work for at least a couple of days, because you need some space outside of work to really think through these issues for yourself. As I say, I was very reluctant. I came to love role play just because I saw how amazing it could be. I mean, I can tell you so many stories. I've seen medical students, doing simulations with actors, and the students afterwards would actually be shaking, with the emotion of it, and they'd say in the feedback afterwards, they'd say, "Look, I knew that was all pretend. I knew it wasn't real. I knew it was just an actor, but the emotions were still there." And you think, well, that is what experiential learning is, and you kind of it's almost like developing a negative. You expose them to that in medical school, so that when they do it in real life, it's like developing that negative, and they're able. It's there somehow, and they're able to put it into practice. And it doesn't matter if they make mistakes, because it's not a real patient. It does matter if they make mistakes when it's with real patients. So I think in this training, we need to get all those concerns out on the table and give the faculty opportunities to work with role play and working with simulated patients in ways that they will do later with the students. And the great thing about this is that you can actually rewind. If you've got a simulated patient, it's a standard session. You would say you've got a simulated patient, and you say, okay, this patient has, shall we say, a suspicious mole, and you're concerned that it could be melanoma, and you're going to refer them. So before you call the patient in, you have a discussion with the students. So you've got about 8 students there. How would you tackle this? What would you say? What do you need to find out? Maybe they get their phones out and look up the information. And then one of them volunteers, they call in the patient, and let's imagine it goes disastrously wrong, and the wheels come off, and they just make a complete mess of it. You can say, okay, time out for a minute, let's stop, patient, just be quiet for a minute. What might you have done differently? And you get them to discuss in the group what went wrong and how they might do things differently next time. And then you can rewind to the point where you say, okay, let's go back to the point where you said, I think I'm concerned about this mole, and see where it goes if you take it a different direction. And God, if only life were like that, you could actually rewind and replay things. But it's a really safe opportunity. But it means that that's quite a tricky thing to do as a teacher. So people need to practice with it before they practice with students. The other thing I think that is really great to do is about writing scenarios for teaching and assessment. So obviously the learning outcomes for the teaching are aligned with the assessment, right? So I very strongly feel that there's nothing wrong with, say, if you've practiced scenario in a teaching session, later to say, okay, that's the assessment. So you could use the suspicious mole one, and you think, well, that's a really fair assessment because they've had a chance to discuss it. They've seen somebody else having a go at it, even if they haven't had a go themselves. If that comes up in the final OSCE, that's really great. So I'm really keen to really align the teaching and assessment so it's really transparent for the students. And also, I think the formative feedback really here is the most important part of it. And so as part of this whole training, I think they need to write the scenarios, think about delivering the training, think about what kind of feedback they're giving formatively in teaching, and then also think about how you would summatively assess this. Because what we want to write into the summative assessment criteria is things like, are they making empathic comments and so on. Now, just a couple more slides. So, formative assessment.
Time is up, Peter. Thank you.
In the teaching,
can you give us a summary, please?
This is a supportive environment where you're really helping them. Weaknesses, mistakes are just a starting point. They're not a sign of failure. The students, I mean, this comes back to questioning medical authority. I mean, they should be able to question each other and question their teachers and try out different things. As I say, it's a safe place. It doesn't matter if they get things wrong, if things go horribly, pear-shaped, they can still rescue it. I think we ask a lot of medical students. They are young. I mean, what 20-year-old has really thought through their own death? Not many, I would have thought, unless they've really had some terrible experience happen to them. And I think quite often they're thinking through those issues as they're working with patients, which is not really fair on them or the patients. So I think this is also an opportunity to give learners just the opportunity to talk through the emotions that they have. Where else do they get it in the curriculum to explore these kind of issues?
Can you hear us, Dr. Washer?
Yes.
Can you
I'm
hear
just about
us?
to finish. Yeah. I've got one more slide. So some final thoughts. It's a serious subject, vitally important to medical practice. There's an evidence base. Medical teachers need to be role modelling their enthusiasm for this subject, and we need to move beyond simple history taking. And the diagnosis is part of it, but the process is really important as well. And at that, I will stop. Thank you very much.
Thank you very much.